Let's review another interesting case. Our first patient is a 36-year-old man who presented with a lower leg mass. Imaging revealed a 2.5 cm lesion arising from a nerve, and the mass was subsequently resected. On low-power examination, the tumor is well encapsulated and shows areas of myxoid change and hyalinization. In this image, we can appreciate the perineurium and a fibrous capsule. On the right side of the field, there are bland spindle cells, while other foci contain epithelioid cells with nuclear atypia. Here is another area demonstrating epithelioid cells with variable nuclear size and shape. Mitotic activity is 2/10 high-power fields, and there is no necrosis. Immunohistochemical stains show diffuse positivity for S100 and SOX10. The question is this a schwannoma or a malignant peripheral nerve sheath tumor, MPNST? Now let's consider a second case. This patient is a 30-year-old man with an upper arm mass. This tumor is also encapsulated but is more hypercellular than the previous case. On high power, we see epithelioid cells with nuclear atypia and prominent nucleoli. Mitotic activity is low, and there is no necrosis. Another area shows round to oval nuclei with prominent nucleoli, features not typical of the bland spindle cell seen in conventional schwannoma. The tumor is diffusely positive for S100 and SOX10. Again, the question arises, schwannoma or epithelioid MPNST? The correct diagnosis in both cases is epithelioid schwannoma. This is a rare tumor, and the diagnosis can be challenging. Historically, some cases have been classified as low-grade MPNST. Epithelioid schwannoma most commonly occurs in the extremities but may also arise in the trunk or visceral organs. Patients range in age from 13 to 80 years. Tumor size varies widely, from 0.25 cm to 23 cm. All reported cases are well circumscribed, and the vast majority are encapsulated. Histologically, these tumors show epithelioid cells arranged in sheets or nests. Myxoid and hyalinized stroma are common. Cytologic atypia, including variation in nuclear size and shape, can be focally striking. Mitotic activity may be increased, up to 9 mitoses per 10 high-power fields in some cases. Importantly, no cases have shown tumor necrosis. Immunohistochemically, all tumors are diffusely positive for S100 and SOX10, and approximately 40% show NE1 loss. Clinically, they are not associated with NF1 or NF2. Most epithelioid schwannomas behave in a benign fashion. However, rare tumors may recur or undergo malignant transformation into low-grade epithelioid MPNST. Distinguishing epithelioid schwannoma from epithelioid MPNST can be difficult, and misclassification is not uncommon. General tendencies include, epithelioid schwannoma is usually superficial, and well circumscribed and encapsulated, while epithelioid MPNST is typically deep-seated and often poorly circumscribed. However, these features are not absolute. Some epithelioid schwannomas arise in visceral organs and can be large, while some epithelioid MPNSTs can occur in the dermis. Features favoring MPNST include, diffuse, marked nuclear atypia, mitotic activity greater than 10/10 HPF, presence of atypical mitotic figures, and tumor necrosis. It is important to note that immunohistochemistry does not reliably differentiate the two, as both epithelioid schwannoma and epithelioid MPNST show diffuse S100 and SOX10 positivity. Classic, spindle cell MPNST, by contrast, is usually only focally positive. Summary: epithelioid schwannoma is a rare, typically well circumscribed, encapsulated tumor that may show focal cytologic atypia and increased mitotic activity. These features can mimic epithelioid MPNST, making diagnosis challenging. Most epithelioid schwannomas follow a benign course, with infrequent recurrences and rare malignant transformation. Features that favor MPNST include necrosis, greater than 10 mitoses per 10 HPF, and diffuse nuclear atypia.